Burns Mechanical Ventilation Wean Assessment Program by Megan Cahalan, Chanel Carbonneau, Colleen Ford, and Emily Kurtek. At the end of this presentation, the student will identify why a ventilator weaning program is necessary. The student will identify or recognize the Burns Wean Assessment Program. The student will become familiar with how the Burns Wean Assessment Program is scored. Also, the student will recognize the limitations to the Burn Wean Assessment Program. Mechanical ventilation weaning programs are necessary due to the fact that weaning predictors, once popular in the 90s, have not proven to be clinically effective. Research in outcome predictors has been abandoned due to the fact that studies of weaning protocols with weaning screens and spontaneous breathing trials have indicated effectiveness in improving patient outcomes when treated with mechanical ventilation. Although these studies do take into account sedatives and glycemic control, there are many other factors that are not taken into consideration when assessing the probable outcome of weaning the patient from ventilation. And costs related to patients being ventilated continue to increase.
What is the Burns Weaning Assessment Program? Burns Weaning Assessment Program is a 26-factor weaning assessment worksheet and scoring instrument that is used to reduce practice variability when weaning patients from mechanical ventilation. The purpose of the Burns Weaning Assessment Program is to address specific elements of care that may impede weaning. The Burns Wean Assessment Program has been in use since the 1990s in the University of Virginia Health System in Charlottesville. The instrument consists of 26 clinical factors used to track patients' progress and signal improvement so that aggressive weaning trials can safely be accomplished. Early testing of the Burns Wean Assessment Program score and its individual factors, specifically in a medical intensive care unit, has been reported.
This slide shows the 26-question Burns program checklist. For example, number 1 asks about the hemodynamic status, which would include stable heart rate, rhythm, and blood pressure without the use of vasoactive or any oral agents administered on an as-needed basis. Number 2, free from factors that increase or decrease metabolic rate, hematocrit greater than 25%, systemically hydrated, nourished, electrolytes within normal limits, correct calcium, pain control, adequate sleep or rest. Number 9 assesses the appropriate level of anxiety and nervousness. Scoring this requires a response from the patient. If the patient cannot respond, a not assessed is scored. For patients that say they are nervous, they can request something for their anxiety. Number 10 is absence of bowel problems, improved general body strength or endurance, findings on chest X-ray improving, respiratory rate and pattern, absence of adventitious breath sounds, secretions thin and minimal, absence of neuromuscular disease or deformity, absence of abdominal distension, obesity, or ascites, oral endotrache tube, cough and swallow reflexes adequate, negative inspiratory pressure less than 20, positive expiratory pressure greater than 30, spontaneous tidal volume greater than 5, vital capacity greater than 5 to 15, pH 7.3 to 7.45, PaCO2 approximately 40 with minimum ventilation less than 10, and PaCO2 greater than 60 with fraction of inspired oxygen less than 40.
How is the Burns Wean Assessment Program scored? The Burns Wean Assessment Program score is calculated by dividing the total number of yes responses by 26. The number 26 represents the total number of Burns Wean Assessment Program factors listed on the checklist. The checklist requires a yes, no, or not assessed response based on the past 24 hours. The yes response indicates that the factor meets the established threshold definition. A no response means that the factor did not meet the established threshold definition. And a not assessed answer means that there's not enough data is available. This response counts as a response of no in the calculation. How is the Burns-Wean assessment put into use? The scoring process draws attention to each of the factors which prompts additional assessment and possible intervention in an attempt to address the factors that are preventing weaning. Patient scores greater than 50 identify the likelihood of being weaned successfully compared to patients with scores under 50. The scores are helpful in care planning and to identify if weaning is possible.
Limitations in the protocol. The Burns-Wean assessment program does not include all potential variables that might influence weaning outcomes. For example, some say pulmonary mechanic variables have a big impact on weaning success, but the BWAP does not include pulmonary mechanics such as rapid shallow breathing index, maximum inspiratory pressure, and minute ventilation. Subjective perceptions are associated with physiological variables, and their interrelationship can make determining weaning readiness a complex task. Interval scale ratings may be more powerful in determining weaning readiness than yes and no responses. Conclusions. There are increasing numbers of older adults in intensive care units for post-operative management of traumatic injuries. Reducing the duration of mechanical ventilation helps to limit costs and complications, but it is important to first assess the patient to determine if weaning will be successful. The comprehensive weaning checklist and scoring instrument has been in use since the 1990s. The BWAP has been found to be more sensitive than other protocols in determining whether a patient is ready to be weaned from mechanical ventilation. Primary assessment variables influencing weaning outcomes have been found to be hemodynamic status, cough and swallowing reflexes, abdominal distension, metabolic status, and PaCO2 and PaO2. No abdominal distension and a PaCO2 of 40 or less have been found to have the strongest correlation with successful weaning outcomes. Interval scale measurements on the BWAP may be more useful in prediction than yes or no answers, but currently the positive-negative answer system has been sufficient in predicting weaning outcomes.